Hello friends, today we will take up one more important topic for discussion, that is the anatomy of the kidney. This is Dr. Yusuf signing from Al University. These are the specific objectives which we will try to cover in this lecture. The first is describe the anatomy of the kidneys regarding their shape, surfaces, borders and state factors of its fixation. The second is describe the relations of the kidney. The third is describe the blood supply of the kidneys. Fourth is describe the lymphatic drainage of the kidneys. Fifth is describe renal nerve plexus and renal innervations. And sixth is describe anterior and posterior surface projections of the kidney with special reference to Morrison's parallelogram. The seventh is state location and formation of the renal angle. Eighth is differentiate between the anatomical positions of both the kidneys. Ninth is identify the sides of the kidney, how to differentiate between the right side and the left kidney. 10th is recognize the relations between kidneys and ribs on both the sides. 11th is list the coverings of the kidneys and describe renal fascia and mention the clinical significance of the renal fascia. The 12th is list and locate vascular segments of the kidneys and explain its clinical significance. 13th, describe the exposure of kidneys from behind. 14th is describe the development of the kidneys and list its congenital anomalies. So these are some of the specific objectives which we'll discuss in this lecture. To begin with, the kidney, the other name for this kidney is renus, or it is also called as nephros. Whenever you talk about the study of the kidney, it will be called as nephrology, because nephro means the kidney, or the renus also. Okay, so as you know, the kidney is a very important organ for excretion, and this is situated in the posterior abdominal wall. If you see in this picture, these are the two kidneys on either side and they are present on the posterior abdominal wall. So this is the duodenal diaphragm, and behind this is the posterior abdominal wall on either side, and they are lying on the posterior abdominal wall, and on each side they are a pair, and one on each side of the vertebral. One vertebral column is in the center, and on beside that will be the on the posterior abdominal wall you can trace this kidney, and they are retroperitoneal, that is they are behind the peritoneum. So these kidneys are retroperitoneal. If you see the shape, they look bean shape, and whenever you study the bean, they say it is the shape. So these terms are can be used vice versa. Okay, so bean shape or kidney shape. Okay, the shape itself is called kidney shape, or it is a bean shape. So the size of this kidney is almost 11 to 12 centimeters in length from upper pole to the lower pole. The total length is almost 11 to 12 centimeters. Half of that is the breadth, so almost 6 centimeters will be the breadth, and half of that will be the thickness. Thickness will be almost 3 centimeters. So it is 12 into 6 into 3. Okay, so the length is 11 to 12 centimeters. Half of that will be the breadth, that is 6 centimeters, and half of that breadth will be the thickness, that is 3 centimeters. Coming to the location of the kidney, as you know, the abdomen is divided into 9 quadrants, and these kidneys occupy almost 4 quadrants. Okay, and they will be occupying the epigastrium, which will be here. A part of it, especially the upper pole of the kidneys, will be occupying the epigastrium, and they will be occupying the hypochondrium. Okay, hypochondrium will be on either on the right side or left side, because on both the sides there are kidney. So the right kidney will be occupying the right hypochondrium, and the left kidney will be occupying the left hypochondrium. Similarly, they will be also occupying the lumbar region. The right kidney will be occupying the right lumbar, and the left kidney will be occupying the left lumbar, and the lower pole as well as the medial part will be occupied by the umbilical region. here will be the umbilical region, so it will be occupying the umbilical region. So they are partly in the right hypochondrium, or the left kidney will be in the left hypochondrium, and partly they will be in the right lumbar region. The right kidney will be in the right lumbar, the left kidney will be in the left lumbar. Then they will be also partly they will be present in the epigastrium as well as the umbilical region. There is no right and left umbilical or epigastrium because they are in the center. These are the quadrants which are in the center. Okay, so they will be occupying almost 4 quadrants on each side. Okay. The extent, if you see the extent, they will be extending from the in comparison to the, whenever we talk about the level, at that time we always think about the structures which are fixed, especially the in case of the thorax and the abdomen, we'll compare it with the vertebrae. So if you compare it with the vertebrae, it will be from the T12 thoracic vertebra up to the lower pole will be up to the third lumbar vertebra. So that will be the extent from the 12th thoracic up to the third lumbar vertebra. And if you compare the right kidney and with that of the left kidney, so the right kidney will be slightly lower. Why? Because the right hypochondrium will be occupied mainly by the liver. So a large organ which will be present sitting here. So this kidneys, if you study the development, it will be actually they will be in the pelvis during development. They have ascended upwards. So when they ascend upwards, the uh, they are held in the position on the, especially on the right side. They are stuck because of the right hypochondrium, which is occupied by the liver. So they cannot extend beyond that. So they cannot ascend more than that. So the right kidney, but on the left side, it is free to ascend upwards. So the left kidney is much more higher compared to the right kidney. So the right kidney is slightly lower than the left one. And it is also seen that the left kidney is little nearer to the median plane. If you take a vertical plane which is in the center, that is called as the median plane. So the left kidney is slightly more closer to the median plane compared to the right kidney. So the weight, if you see the weight, as in case of any most of the organs in the body, it is slightly higher in weight compared in the males compared to the females. So it is almost 150 grams in case of the males and slightly lower in case of the females, almost 130 to 135 grams in case of female. And if you see the color, they are almost reddish brown in color. As you can see here, they are almost reddish brown in color. Coming to the external features of this kidney, each kidney will have 2 poles. As I was discussing, there are 2 poles. One is at the this is the upper pole and the lower pole. Here also we have the upper pole as well as the lower pole. So there are 2 poles, 2 borders. So there are 2 borders. One is the medial border, which is concave, where we can see the hilum, the structures where we will be entering and coming out. So here will be the hilum. So it will be near the medial concave border. And the other border is the lateral border, which is convex. Here also you can see the concave border as well as the convex border. So there are 2 borders, 2 poles and 2 surfaces. One is the anterior surface and the posterior surface. The posterior surface is the surface on which the kidney will be lying. Okay, so the bed of the kidney will be on the posterior surface, and here will be the anterior surface, what you are seeing. So there are 2 poles, 2 borders and 2 surfaces. 2 poles are the upper and the lower pole. 2 borders are medial border as well as the lateral border. Medial border is concave and the lateral border is convex, and 2 surfaces, anterior and posterior surface. The left kidney is little longer compared to the as well as narrow compared to the right kidney. There is an objective where we are supposed to compare the right kidney and the left kidney. So I did not put it as a separate column to differentiate between the right and left. But whenever I will be discussing this lecture throughout, I will be explaining the differences between the left kidney and the right kidney, and how to identify the left kidney and with the left kidney. Okay, so if you see, compare, always the left kidney will be slightly longer as well as narrow compared to the right kidney will be much more broader. As I said, when it is ascending upwards, it will be held uh, because of the liver which is in the right hypochondrium, so it becomes much more broader as compared to the left kidney. If you compare the borders, the poles of the kidney, the upper pole is mainly occupied by the gland which is called as the suprarenal gland. If you see the next picture here, you can see here these are the suprarenal glands. So this is how you can identify the upper pole. They are usually, whenever you see the specimen, it will be occupied by the suprarenal gland. Even if it is not there, the upper pole is much more broader compared to the lower pole. Lower pole will be narrow and the upper pole will be much more broader. And the lower pole, there is no organ which is sitting on the lower pole. Only in the upper pole it will be occupied with the suprarenal gland, and the lower pole will be free. If you put a line horizontally, that is called as, there is a plane called as the transpyloric plane. It is called as transpyloric because it passes through the pylorus of the stomach, so that is called as the transpyloric plane. Okay, so here will be the stomach which will be sitting there. So if a plane passing through the pylorus of the stomach, if it is put, then if you see here the right kidney, because the right kidney is slightly lower, this transpyloric plane will be passing through the upper part of the hilum. So it will be passing through the upper part of the hilum, but the left kidney is higher, so it will be passing, the same plane will be passing through the lower pole of the left kidney. Okay, the lower part of the hilum of the left kidney. So it will be passing, this transpyloric plane will be passing through the upper part of the hilus of the right kidney and lower part of the hilus of the left kidney. This indicates that the right kidney is slightly lower compared to the left side. So this plane is called as the transpyloric plane. And if you see the long axis of the kidney, long axis will be passing through the two poles, the upper pole and the lower pole. This is how the long axis of the kidney is present. So if you see the long axis of the kidney, this will be not vertical but slightly oblique, with the upper pole directed toward the median plane. So the upper pole is directed toward the median plane. It is more, the upper pole is more closer to the median plane on either side, both the kidneys, and this plane here, the long axis will be passing like this. So the upper pole is more towards the median plane compared to the lower poles. Lower poles are away. So this line, which is the long axis of the kidney, is directed downwards as well as laterally away. Okay. And if you compare the surfaces of the kidney, I said there are two surfaces, anterior surface as well as the posterior surface. The anterior surface is in relation to the peritoneum and all the organs which are there in the abdomen. So this surface is much more irregular, and the surface is not smooth but irregular surface. But the lower, the posterior surface, which is where or on the surface on which it is lying and is in contact with the posterior abdominal wall, it is much more flat compared to the anterior surface. The posterior surface is flat and smooth compared to the anterior surface, which is irregular and slightly rougher. Okay, so this is how can differentiate. The posterior surface will be much more flat because it will be lying on the posterior abdominal wall, and the anterior surface will be much more irregular, and this surface will be in contact with the peritoneum as well as all the abdominal organs which are present here. Okay, so this is how we can differentiate the anterior surface and the posterior surface. And if you compare the borders, we have discussed already the medial border where we can see the hilum. This is the hilum of the kidney. Hilum is that part of the organ where the structures will be either entering the kidney, the organ, or coming out from the organ. So this is the hilum of the kidney on either side, and this is the area where we can see the medial border, and this medial border is much more concave, and the lateral border is convex. And the arrangement of the structures at the hilum is very typical, and this is also a very important feature with which you can differentiate between the right kidney and the left kidney. Okay, so what are the arrangement of the structures here? Which are the structures here, and what is the arrangement? Okay, so anterior posteriorly, if you see, the first structure will be the right or the left renal vein. For the right kidney it will be right renal vein, or for the left kidney it will be the left renal vein. So it will be the first one is the most anterior structure will be the renal veins. Okay, then the next structure will be the artery, that is the renal artery. So if you can see here, this is the inferior vena cava. This is the inferior vena cava, and this renal veins are draining directly into the right and the right kidney as well as the left kidney will be draining into the inferior vena cava. Okay. Okay. So here you also can see this is the inferior vena cava, and these are the renal veins. The next structure deep to that will be the renal arteries. The renal arteries are the main arteries which will be supplying the kidney. So these are direct branches from the abdominal aorta. This is the abdominal aorta. So it will be giving branches on either side. Here also you can see this is the abdominal aorta, and these are the branches. So I repeat that the renal arteries are branches directly from the abdominal aorta. These are lateral branches from the abdominal aorta. The third structure, which is the deep posterior structure, will be the renal pelvis. Renal pelvis, you can see here, this is the renal pelvis which contains as the ureter. Here also you can see this is the renal pelvis which contains as the ureter. So this is the most posterior structure. Okay, so this is the arrangement of the structures at the hilum, and as I said, the arrangement of structure is very important to identify the side of the kidney. So whenever you get a kidney, if it is separated from the cadaver and it is given as a single kidney, then you should be able to identify. So keep the most anterior structure will be the renal vein, and the most posterior structure will be the renal pelvis. So if you identify the structures, then it will be much more easy to identify. Okay. Between the artery and the vein, how do you identify? There will be no difference in the color. Here in the pictures it will be differentiated, but actual specimen the artery and the vein will look very similar, but you should know the way with which you can differentiate between an artery and a vein. Artery will have a thicker wall and the lumen will be smaller, and the vein, which is most anterior in this case, will be having a wider lumen as well as the wall will be thinner. So whenever you touch and feel it, the veins will be collapsed, and you can easily feel the wall. It is much more thinner compared to the arteries which are behind the vein in this at this hilum. Okay, so try to keep the vein the most anterior. Identify the vein as the most anterior structures. The artery will be behind that, it will be in the middle, and the most posterior structure will be the pelvis. So if you identify the pelvis and if you put it on the posterior side, then you can easily identify that it is the artery, the right kidney or the left kidney. The others method by which you can identify is the other feature will be the upper pole. Always put the upper pole on the upper end, and usually it can be identified by the presence of the suprarenal gland or the adrenal gland, which will be sitting on the upper pole. And if it is not there, still you can identify, because the upper pole is much more broader compared to the lower pole. And always the kidneys should not be totally vertical but slightly oblique, by the head, the upper pole being more close to the median plane compared to the lower pole. Okay, and the fourth identifying feature will be the surfaces. The anterior surface, as I said before, it will be much more irregular, and the posterior surface will be much more smooth. Okay, so try to put the posterior surface which is smooth on the posterior side. Okay, so the posterior surface is the surface on which the kidney will be lying on the posterior abdominal wall. Okay, so with these features you can easily identify whether this kidney is the right kidney or the left kidney. So the most easiest way of identifying is if you identify the structures at the hilum. Identify the most the anterior structure is the vein, so try to keep the vein in the front and the pelvis in the behind, then you can identify whether it is the right side. And always the pelvis will be directed downwards, always directed downwards, because it is going down into the pelvis, opening into the bladder, so it will be directed downwards. So these are some of the features with which you can identify the right kidney with the left kidney. Now coming to the capsules or the coverings of the kidney. So the kidney is not left alone, but it is covered by very important structures or the coverings of the kidney. So the most anterior, the most closest to the kidney will be a fibrous capsule. It is nothing but the condensation of the tissue of the kidney. Okay, so this is the capsule of the kidney. This is the kidney seen by taking a section in the abdomen. So this is the posterior abdominal wall here, and this is the anti-abdominal wall in the front, and here this is the peritoneum, and here will be the abdominal organs which will be present. So you can see here the peritoneum is covering only the anterior surface of the kidney. Okay, so what are the coverings of the kidney? This is the section of the kidney, and you can see the most closest to the kidney will be the fibrous capsule, which is, as I said, it is the condensation of the tissue of the kidney. The next covering is called the perirenal or perinephric fat. So there around the kidney, this will be the fat which will be present. So if you have seen the real kidney, or if you have seen the kidney from the sheep or goat or somewhere some animals, you might have seen that always the kidney will be covered by some quantity of fat. When you remove it, it will be always covered. This is the perinephric fat which is around the kidney. So this is called as perinephric or the perirenal fat, because it is outside the kidney. Then after that will be a very important fascia which is called as the renal fascia. A very important covering is called as the renal fascia. This is the renal fascia. Okay, so it is the renal fascia. So the most deepest will be the fibrous capsule. Outside that will be perinephric fat or the perirenal fat, and outside that is the renal fascia. And the outermost will be outside the renal fascia. This is called as the, especially it is present on the posterior near the posterior surface. This is called as the paranephric fat. This forms the cushion or the bedding of the kidney. So this is called as the pararenal or paranephric pad of fat. So this is the paranephric fat which is present especially on the posterior wall, which form the bed for the kidney, and this gives the smooth cushioning effect to the kidney if there is any vibration, jumping or something like that. So the kidney is a very well protected organ which is seated in the posterior abdominal wall, and here you can see here so many muscles and other things are totally giving protection to the kidney, and there are coverings within itself which will give extra protection to the kidney. Okay, so as we have studied, the outermost will be the paranephric fat, which is present in the especially the posterior abdominal wall, then behind which form the bed for the kidney. Then deep to that will be the renal fascia, and deep to that is the perinephric fat which is present around the kidney, and the deepest which is totally adherent to the kidney is the fibrous capsule of the kidney itself. Okay, and this is the hilum where the structures are either passing inside or coming out from the kidney, and here you can see the inferior vena cava, and this is the abdominal aorta. Okay, so these are the four coverings of the kidney from inside to outside, that is the fibrous capsule, perinephric fat, renal fascia, and the paranephric fat. Okay, among these the most important will be the fascia called as the renal fascia. We have already seen this is the renal fascia. So it is nothing but the condensation of the extraperitoneal connective tissue. Okay, so it is because it is present outside the kidney, so it is called as the extraperitoneal connective tissue around the kidney. So this has two layers, as you can see in this picture, an anterior layer as well as a posterior layer. Okay, so the anterior layer is thinner, and this is called as the fascia of the toral. So this is the fascia of the total, and the posterior layer is much more thicker compared to the anterior layer, and this is called as the fascia of the Zuckerkern. So this is the fascia of the Zuckerkern. So this is the fascia which form the posterior layer, and this is the anterior layer. So both these layers, if you can see here, they are coming close to each other on the lateral border of the kidney. Okay, so they both meet at the lateral border of the kidney, and they continue as the transversalis fascia, or it will continue into the transversalis fascia. Okay, so transversalis fascia is the deepest fascia after the three layers of the anti-abdominal wall. So these are the three muscles of the anti-abdominal wall. Deep to that is the fascia called as the transversalis fascia. So this renal fascia will continue into the transversalis fascia. And this fascia is also not only continues on the lateral side. Medially they don't meet each other, but the laterally they are meet each other. The anterior layer and posterior layer join together and continue as the renal fascia and continues into the transversalis fascia. Similarly, this fascia also continues upwards toward the upper end of the upper pole of the kidney. At the upper pole, both the fascias will meet each other at the upper pole, and they divide, and then they cover the suprarenal gland also, or the adrenal gland. So before the it covers the suprarenal gland, it will both the layers will meet each other at the upper end of the kidney, and then they split and cover the suprarenal gland, and then they continue up to the dome of the diaphragm. So this arrangement is very important. Okay, and this upper end which will be going and getting inserted to the dome of the diaphragm, this is called as the suspensory ligament of the adrenal gland. This is called as suspensory ligament of the adrenal gland because it will be suspending both the kidney as well as the suprarenal gland, especially the suprarenal gland, because suprarenal gland, if you can see here, so it is totally covering the suprarenal gland and it is holding in the upper end. This is important because if you see the development of the kidney, as I said before, they will be actually initially they will be in the pelvis, they ascend upwards. Okay, so sometimes the kidney might not ascend upwards totally into the actual position, and it might be much more below. So when it is much more below, the suprarenal gland, which is actually developed in this region, so it will be always there. So the kidney and the suprarenal gland will be separated, but still the suprarenal gland, it will be in its position because of this ligament, which is called as the suspensory ligament of the suprarenal. That's why it is called as not the suspensory ligament of the kidney, but the suspensory ligament of the suprarenal gland, because it will be mainly holding the suprarenal gland in its position, even though it covers the kidney, but sometimes the kidney might be much more lower down. So this indicates that the kidney has ascended upwards, but the suprarenal gland has developed in its position where it will be finally seen. Okay, So this is the arrangement of the renal fascia. So laterally it will be continuing into the transversalis fascia. The anterior and posterior will meet each other and continues into the transversalis fascia. Superiorly also they meet each other at the upper pole of the kidney, then split and covers the suprarenal gland and goes up to the diaphragm, and then they form something called as the suspensory ligament of the suprarenal gland or the adrenal gland. Now we should know what are the factors which are keeping these kidneys in their position. As we have seen, the kidneys are in the hypochondrium as well as the lumbar regions. So why not in the iliac, in the lower part? Why? How come they are held in a much more higher position? So what are the factors which keep the kidney in their position? Okay, so there are three factors. The most important will be the first is the pressure exerted by the neighboring viscera. If you know that the abdomen has a positive pressure and it is much more higher, okay, and this pressure within the abdomen will keep the kidneys in their position. The second important feature factor is the renal fascia, which we already studied. So as you have seen, the renal fascia, which will be continuing, the anterior and posterior will continue on the lateral side as well as in the upper region, okay, which form the suspensory ligament of the adrenal gland. So this renal fascia as well as even the renal fat which is around it, which will be keeping the kidney in their position. And the third as well as the most weakest as well as the least important will be the pedicles of the kidney. So these are the pedicles of the kidney which continue down as the ureters. Okay, so these structures also hold them in their position, but these are the weakest and they have the least importance. The most important will be the intra-abdominal pressure, and the second important feature is the renal fascia, which will be holding it on the lateral side as well as at the upper end as well as the renal fat, and the least important will be the pedicles of the kidney, which will hold the kidney in its position. Now coming to a very important area which is called as the Morrison's parallelogram. So this Morrison's parallelogram is a parallelogram which is drawn in the lower part of the back. So here, so this is where the Morrison's parallelogram is drawn. Okay, so how it is drawn and why it is important we'll discuss. Okay, the first is how it is drawn. Okay, so this is drawn by two vertical lines. The first vertical line will be almost 2.5 centimeters from the median plane. So this will be the median plane in the center. So the first line will be almost first vertical line will be almost 2.5 centimeters from the median plane, and the second vertical line will be almost 9.5 centimeters from the median plane. Okay, these are the two vertical lines drawn. Then we have to draw two horizontal lines. The first one is at the level of T11. Okay, the at the tip of the spinous process, these are the spines of the vertebrae. So from the tip of the spinous process of the 11th thoracic vertebra, a horizontal line is drawn, and the second is drawn at the level of L3. Okay, so how do you count the vertebrae? The vertebrae can be counted from the 7th cervical vertebra, which is called as the vertebral prominence, which can easily, the spine can be felt the lower part of the back of the neck. From there you start counting the vertebrae, and at the level of T11 you draw a horizontal line. At the level of the second line will be drawn at the level of L3. So these are two horizontal lines, and initially we have drawn the two vertical lines. So these four lines will make a parallelogram. This is called as the Morrison's parallelogram. So this Morrison's parallelogram is very important, because if you want to trace the kidney and if you want to operate on the kidney, this is the parallelogram where you can trace the kidney as well as you can operate on. Okay, so this is a very important parallelogram where within which will be the kidneys. Okay, both on the right side as well as on the left side. Draw two vertical lines. The first line, vertical line, will be almost 2.5 centimeters from the median plane. The second will be from almost 9.5 centimeters from the median plane. Then two horizontal lines. The first one will be from the T11 process, and the second will be at the level of L3 from the spine of the third lumbar vertebra. Then you get a parallelogram that is called as the Morrison's parallelogram. And if you want to trace the hilum on the kidney, it will be almost 5 centimeters. The first line is 2.5 centimeters. Again from there 2.5 centimeter becomes 5 centimeters from the median plane, and at the level of L1 vertebra, in between these two, T11 and L3 will be the L1. So almost at the level of L1 vertebra will be the hilum of the kidney. So this Morrison's parallelogram is very important if you want to trace, because as we have studied that the kidneys are in the posterior abdominal wall, and this is the much more easy way to trace the kidney from posterior abdominal wall. So if you want to identify the kidney from behind, and if you want to operate or expose the kidney, so you should first draw this Morrison's parallelogram, and from there you can continue forwards. Now coming to we'll study some of the relations of the kidney. So what are the anterior relations? As we have seen that the kidneys are in the posterior abdominal wall, and all the abdominal organs which are there, which are in the abdomen, will be almost in anterior relation to the kidney. So the anterior relation of the kidneys are very important because they are in contact with the abdominal organs. And if you compare, it will be different on the right kidney and the left kidney. Okay. At the upper pole, as we already seen, it is much more broader, and you can see trace the suprarenal gland. This is how the adrenal gland or suprarenal gland will be sitting on its upper pole. So the upper pole is occupied by the suprarenal gland. Then on the right side, the kidney is, as we already seen, it is in relation to the liver. Okay, so most of the area on the lateral border as well as the anti-surface will be in the upper part will be covered by the hepatic area, that is the area which is with the liver. Medially, on the almost on the medial border, it is in relation, the right kidney is in relation to the, if you see this picture, okay, so here you can see here, this is the duodenum. So especially the curvature of the duodenum, that is the second part of the duodenum, will be on the actually the medial border of the kidneys. So the duodenum will be in relation to the medial border of the right kidney. Then below this liver will be the colon as well as the part of the small intestine, the large intestine as well as the small intestine. So this is the area which is in relation to the colon, and some of the coils of the intestine will be present here. This is especially the jejunum. After the duodenum, this here will be the duodenum, and here will be the jejunal part of the small intestine, which will be in relation. So these are some of the relations of the right kidney. The most in the upper pole, most superiorly on either side, it will be suprarenal gland. Below that, on the right side, it will be the liver, and on the especially near the medial border will be the curvature of the duodenum, and here will be the colon, and the jejunal folds of the small intestine will be present on the anterior relation. So these are some of the relations of the right kidney. Compare it with that of the left kidney. At the upper pole, it will be the same suprarenal gland which will be occupying, but the relations on the left side, it is quite different from that of the right side. So this especially the lateral border will be instead of the liver on the left side, it will be occupied by the spleen. So the lateral border of the left kidney will be in relation to the spleen. Then a very important relation near the hilum will be the pancreas. Very important relation, especially the tail of the pancreas. Okay, so here it will be in relation to the pancreas, as well as the spleen, as well as hilum of the kidney. So here there will be very important ligament called as the renal ligament. And above that, here will be partly, it will be in relation to the stomach. This is called as the gastric area, and below it will be the colon, as well as the jejunal part, just like that of the right side. Here also the lower part will be occupied by the jejunal, as well as the colic areas. So these are some of the relations of the right kidney with that of the left kidney. So the relations, anterior relations of the right kidney is different from that of the left kidney. And here you can see the peritoneal folds. As we have studied that the kidneys are retroperitoneal. So the kidney is only covered by partly by the peritoneum, especially only on the anterior surface. So these are some of the relations of the peritoneum. So if you can see here, the liver which is covered by the peritoneum also covers partly the anterior surface, as well as here you can see the small intestinal folds of the peritoneum also cover partly the kidney. And here you can see the colon, which is retroperitoneal, that especially the right colic flexure. So it will be almost divide of the peritoneum here, as well as even the duodenal part. And on the left side you can see here again, here at the upper pole, because it is occupied by the suprarenal gland, here also it is devoid of the peritoneum. Here on the left side, because the stomach is covered by the peritoneum, also covers partly the kidneys. And here the lower part, again the jejunal folds will be covered by peritoneum, and it covers partly the anterior surface of the kidney also. But here you can see the pancreas, and here this part, all these parts are devoid of the peritoneum. So the kidneys, as you should know, that they are present retroperitoneal, so they are partly covered anteriorly, only on anterior and slightly on the lateral side with the peritoneum. If not, the posterior surface is totally devoid of the peritoneum. Now coming to the posterior relations. The posterior relations are much more similar on both the right and left side. So that's why it will be much more easy. Especially the posterior relation is with the posterior abdominal wall. Okay, especially the three muscles which are there. Okay, the most medial one of either side will be the psoas muscle, as well as just lateral to that will be the other muscle called as the quadratus lumborum, and the most lateral will be the transverse abdominis. Similarly here also on the left side it is same, psoas major, then quadratus lumborum, as well as the transverse abdominis. Here you can see this is the psoas major, then we have the quadratus lumborum, and the most lateral will be the transverse abdominis. So these are the three muscles which are in relation to the posterior wall. And upper pole, as you already see, that it will be occupied by the suprarenal gland. So these are some of the relations posteriorly. So this is how it looks like when you see the kidney, when you remove all the abdominal organs and then try to trace the kidneys which are in the posterior abdominal wall. So here you can see the peritoneal partly covers the kidneys. So these are the anterior relations. So here you can see the tail of the pancreas, especially, which is a very important relation, which is towards the left side near the hilum of the left kidney. So you have already seen. So here will be the pancreas, here will be the tail of the pancreas. So the tail of the pancreas is traced up to the hilum of the kidney, left kidney. Okay, so here it is in relation to the hilum of the kidney, and here will be the spleen, okay, which is not shown here. So these are some of the posterior relations of the right kidney as well as the left kidney. Both the posterior relations are much more similar on the right and left side compared to the anterior surface, which is the anterior surface relations of the right and left are quite different. Okay, so these are some of the relations of the relations anteriorly as well as posteriorly. One more very important relation of the kidneys is the 12th rib. So as you know, we have studied that the right kidney is much more lower compared to the left side. And why, you already know, because the right side, the right hypochondrium is occupied by the large liver, so the kidney cannot ascend upwards, so the right kidney is much more below. So this gives a different relations with that of the 12th rib. As you know, the 12th rib is present, can be traced only posteriorly, and it is a much more small rib, and it is floating freely, free rib or the floating rib. So this relation of the 12th rib relation with that of the kidneys is very important, why we will discuss again later. So see here, if you see the 12th rib, this 12th rib is passing through the middle part of the kidney, especially middle as well as on the lateral boundary, near the lateral boundary of the 12th rib. But the 12th rib, compare it with that of the left kidney, it will be passing near the hilum of the kidney. So these are because of the left kidney is much more higher, so it passes through the hilum, and in case of the right kidney, it will be passing through the lateral border of the right kidney. Okay, so these are the relations of the 12th rib. Why it is important, we will discuss now here. Clinically, there is a very important angle in relation to the kidney. This is called the renal angle. So, what is the renal angle? We'll understand first, then we'll study the importance of this. Renal angle is an angle which is in the lateral border of the erector spinae. If you see the posterior abdominal wall, there are two muscles on either side, or there are a pair of muscles on either side of the vertebra. These are called as erector spinae. As well as the name indicates, they will be helping in the erection of the spine, or the verticality of the spine. It will keep the person erect. So these are called as erector spinae on either side of the vertebral column. So this will be the muscle. This is how it looks like. Okay, so almost on either side of the vertebral column. Okay, so this will be the lateral border, this is the medial border, this is the upper and lower borders. Okay, so this is called the erector spinae. So this renal angle is between the lateral border of the erector spinae. So this is the lateral border on either side. Here is the lateral border of the erector spinae and the 12th rib. We have studied the 12th rib. So between the 12th rib and the lateral border of the erector spinae, there is an angulation. This is called the renal angle. So this is on the left side, and here will be on the right side. This is the lateral boundary of the erector spinae, and this is the 12th rib. And between there is a small angle. This is called as the renal angle. So what is this renal angle? So this is a very important angle, and here the lower part of the posterior surface of the kidney lies below the renal angle. Okay, the posterior part of the posterior surface of the kidney lies below the renal angle, and it is not encroached by the costodiaphragmatic recess of the pleura. So the pleura at this angle is not present. The costodiaphragmatic pleura is much more higher compared to this angle. Okay, and what's the importance of this angle? Especially medically, this is the site from where the renal colic pain, the pain of the kidneys, these are called the colicky pain. So this renal colic pain starts from at this angle, renal angle, and the typical feature of this pain is it begins at this angle and it winds around and goes up to the groin, up to the genital region. So this is called as the pain starting from the line. This region is called as loin, and it goes up to the groin. So this is the typical feature of the pain of the kidney, that it starts from the back and it goes winds around on the lateral side of the abdomen and goes up to the groin into the genital region. So it begins from the renal angle. So that's why this is very important angle. So whenever the pain of the kidney is there, so you can easily differentiate between the pain of the kidney and the back, that the pain of the back will be in the back. It will not go somewhere else. But the typical feature of the pain of the kidney is it begins from the renal angle, that is called as the loin, and winds around the lateral side and goes up to the groin. This is the typical feature with which we can say easily that this is the pain starting from the kidney. And very importantly, the surgical incisions are taken from this angle. Okay, the kidney is exposed retroperitoneally, because anteriorly if you start tracing it from the anterior wall, then it is difficult, because there are so many the organs which are in the abdomen. We have to separate them, then we have to cut the pleura, the peritoneum, then go behind. Okay, without touching that, if you go from behind, easily you can go retroperitoneally and trace the kidney. Okay, so that's why the kidney is exposed retroperitoneally from behind by an oblique incision taken from the renal angle. Okay, so here from here there will be an incision taken, and it will again winds obliquely and winds behind. Okay, so this is also a typical incision which is taken for the kidney. Okay, so whenever you see an incision on the patient, which is beginning from the renal angle and it is oblique and going toward the lateral side, then you should know that some surgery was done on the kidneys. Okay, and most important clinically is sometime there will be 12th missing rib. So you should always keep in mind that 12th rib sometime it might be missing. So if the especially the surgeons, if they miss this feature, or sometimes even there might be a very short 12th rib. So if the surgeons, if they miss this point and they take that 11th rib as the 12th rib, and if they start taking incision from there, from the 11th rib, then the incision will be much more higher, and that might lead to puncturing of the pleural sac, especially if as we said, it will be going into the costodiaphragmatic recess, and then if you puncture the pleura, then it might lead to severe respiratory complications. Okay, so that's why this renal angle is very important, and you should always see that the 12th rib, it is taken from the between the 12th rib and the lateral border of the rectus spinae, and always make sure that this is the 12th rib, not the 11th rib, because sometimes the 12th rib might be very short, or sometimes it will be totally missing. So at that time, especially the surgeons might miss this point, and if they take the incision much more higher, they might injure the pleura itself, and they are going to puncture the pleura, and that might lead to some other complications, especially leading to severe respiratory distress, and sometimes maybe death also. So that's why you should be very careful, especially when you are tracing the renal angle. Always remember that the renal angle is between the 12th rib and the lateral border of the rectus spinae. Now coming to the blood supply of the kidneys, the arterial supply, as we already see, is by the renal artery, which is a direct branch arising from the abdominal aorta. This is the abdominal aorta, and on either side it will be giving branches which are direct branches from the abdominal aorta. These are called as the renal arteries. If you see this renal artery, when the renal artery start, it will be a single artery on either side, but as it comes toward the hilum, it divides into multiple branches. Okay, so these are called as the segmental branches. So near the hilum, the renal artery divides into an anterior and posterior division, and from there it gives rise to smaller branches. These are called as segmental arteries. These are called as segmental arteries, which supplies vascular segment on each side. So this renal artery will be divided into anterior posterior branches, and these are further divided into segmental arteries. So these segmental arteries will supply each particular area of or a segment of the kidney. These are called as vascular segments. This also indicates that the kidney was initially in a lobulated fashion, and it was multiple lobes which later joined together. When we study the kidney, at the time we will discuss further. So you should know that there will be vascular segments within the kidney. So there are 5 vascular segments which have been identified. The first one is called as the apical segment which will be at the upper pole of the kidney. Then we have the upper as well as the middle segments, so which will be present in the anterior part or on the medial near the medial bottom. Then the lower pole of the kidney will be supplied by a separate segment, and the posterior segment will be a separate segment. So the apical segment, lower segment, in the middle part it will be upper and middle, and there will be a larger segment in the posterior side, that is called as the posterior segment. These are called as the vascular segments of the kidney, and each segment is supplied by a separate segmental artery. So this is how actually the arteries, the renal artery is divided into branches. The renal artery, as I said, is a direct branch from the abdominal aorta. Then this continues as the segmental artery. Then it divides into lobar arteries, and then these lobar arteries will be further divided into 2 to 3 interlobular arteries, which will be between the two lobes. Then it goes near the upper surface, the outer surface near the pyramids, the base of the pyramid. We will talk about the pyramids later. So there it will form the arcuate arteries. Then they are divided into smaller branches called as the interlobular arteries. So these are the lobar, these are interlobular arteries, and further they break into smaller arteries called as the afferent glomerular arteries, which will be supplying the glomerulus, which will form the glomerulus. And then it will be further divided into efferent glomerular arteries, which will be smaller branches from the glomerulus, and then they form the peritubular capillary plexuses. So this is how the renal artery is divided into smaller and smaller segments, and then it is supplying the kidneys. Then coming to the venous drainage, the venous drainage starts from the peritubular capillaries where the arteries end. These are called as the capillaries, and from these capillary plexus, the venous blood will be drained into interlobular veins, and from there into arcuate veins, then into the interlobular veins, and from there into the renal vein, and renal veins will be finally open into the inferior vena cava. So this is how the veins are draining into the inferior vena cava. So the venous drainage is into the renal veins. So these are the renal veins which will be draining into the inferior vena cava. Coming to the lymphatic drainage, it will be draining into the lateral aortic group of lymph nodes. Just beside the aorta, there will be lateral group of aortic group of lymph nodes, and these will be draining. The kidneys will be draining into this lateral aortic group of lymph nodes, which are at the level of the origin of the renal arteries. Just beside here will be the lateral group of aortic nodes, and so these kidneys will be draining into this lateral aortic group of lymph nodes. Coming to the nerve supply is by a plexus that is called as the renal plexus. It is an autonomic plexus and an offshoot of the celiac plexus. The main plexus is the celiac plexus. From there, a plexus arises which will be supplying the kidney. This is called as the renal plexus. So this has a sympathetic component coming from the T10 to L1, chiefly the vasomotor, and the afferents will be coming mainly from the T10 to T12. So this is the nerve supply of the kidney. Now coming to the structure of the kidney, okay, which can be seen by the naked eyes. If you take a section of the kidney, so this is the section of the kidney taken, what is a vertical section, and you can see some of the things which can be seen even by the naked eyes or with a using a hand lens. So what are the things which can be seen by the naked eyes? So you can differentiate between that. If you take a section, at that time you can see a outer covering. This is called as the renal cortex, a reddish brown outer layer which will be present, and inside we can see the inner medulla, which will be much more paler compared to the cortex. So you can differentiate two areas in the section of the kidney, the outer cortex and inner medulla, which is paler. And also you can see small spaces here. These are called as the renal sinuses, small spaces. The renal medulla is made up of 10 conical masses called as the renal pyramids. If you can see here, there are conical pyramids here with the apex directed towards the hilum of the kidney, Okay, and the base is toward the outer border of the kidney. Okay, lateral border or the outer border. So this is the base here of this pyramid, and the apex directed toward the hilum. Okay, so these are almost 10 to 12 conical masses, which are called as the renal pyramids. Renal pyramids. As I said, they will be directed to the apex of this will be directed toward the renal papillae. Renal papillae, which will be indent into the minor calyxes. We'll talk about this calyces later. Okay, so they are directed towards the hilum. This renal cortex is divided into two parts. So the cortex, as we see, is the outer part. It will be divided into two parts: a cortical arch or cortical lobules, which form the caps covering or the cap for the bases of the pyramid. These are pyramids, and just above the bases will the caps. These are called as the cortical arches. Here will be cortical arches, which form the cap for the base of the pyramid. Then in between there are something called as the renal columns. These are renal columns which dip in between the pyramids. Between the pyramid there will be renal columns. So there are renal cortical arches and the renal columns. Each pyramid along with the O-line cortical arch forms a lobe of the kidney. So we have seen that the kidney is divided into lobes. So this kidney is divided into lobes by the pyramid as well as the cortical arches together. This whole thing is called as one pyramid. So as I said, each renal pyramid along with the cortical arch form one lobe of the kidney. So the kidney is made up of lobes. So each pyramid along with the cortical arch. Cortical arch is the part of the cortex which is just which form the caps for the pyramid. Okay, so that together the pyramid with the cortical arch form one lobe of the kidney. Apart from that, there are small spaces. These are called as the renal sinuses. So these are the renal sinus is a space that extend into the kidney from the hilum. So this is the hilum of the kidney, where the structures, the renal artery and the renal vein as well as the renal pelvis will be either entering or coming out, and this is the hilum, and there are small spaces. These are called as the renal sinus. So these renal sinus will contain a small branch of the renal artery, a tributary of the renal vein as well as the renal pelvis itself. Okay, so here you can see the artery and the vein within the sinuses. So these are the branches of the renal artery as well as the tributaries of the renal vein. So we can also see something called as the renal pelvis. What is this renal pelvis? This is nothing but the continuation, upward continuation of the ureter, or the renal pelvis, to be more specific, will continue downwards as the ureter. So this is a large dilated part which is from the part of the collecting part of the urine. So this is called as the renal pelvis. If you see this renal pelvis, it divides into 2 to 3 major calyces. If you can see, this is one division, this is the second division. Okay, there might be a third division, sometimes 2, sometimes 3 major divisions of the renal pelvis. This is called as the calyces or calyx. To be the singular part of this calyces is calyx. Calyces is the plural form. Calyx means it looks like the cup of a flower. That's why it is called as calyx. So each calyx, major calyx, will divide into a smaller division. These are called as minor calyces, or the minor calyx to be singular, and minor calyces will be multiple plural form of the same. So this will be divided into 7 to 13 minor calyces. So you can see the division of this. This is the major calyx, which divides into minor calyces, 7 to 13. And this will be expanded. These minor calyces will be expanded, and within this expanded part there will be indentation of the pyramid of the pelvis. The apex of the pyramid will be opening into these calyces. So 1 to 3 renal papillae or the renal pyramids will be opening into this minor calyx. So to keep it simple, here they have shown only single papillae, renal papillae, which is opening into the minor calyx, but it can be 1 to 3 minor calyces. Renal papillae will be opening into each calyces. 1 to 3 renal papillae. Renal papillae are nothing but the apex of the pyramids, which will be opening into the minor calyx. So the minor calyx are 7 to 13, and the major calyces will be 2 to 3. Now talking about the microscopic, some of the important features. I will not go into detail, so that will be in a separate lecture when we discuss the histology of the kidney. At that time we will be discussing in detail. To be just a brief introduction of the microscopic feature of the kidney, or the histology of the kidney. So the kidney is made up of 1 to 3 million uniferous tubules. 1 to 3 uniferous tubules. Okay, this consists of two parts, nephron as well as the collecting tubule. So usually they say 1 to 3 million nephrons. To be more specific, it should be 1 to 3 million uriniferous tubules, which are divided into nephron as well as the collecting part. Okay, so uriniferous tubules will be divided into two parts. One is the nephron part and the second is the collecting tubules. Okay, so the nephron is the secretory part, which is the functional unit of the kidney. The most important functional unit of the kidney is the nephron. So this nephron is again divided into renal corpuscle. So if you see here, this is called as the renal corpuscle. Okay, so the whole thing is the renal corpuscle. This renal corpuscle also called as the malpighian corpuscle. So renal corpuscle or the malpighian corpuscle, it is divided into two parts. One is the glomerulus and the Bowman's capsule. This is the glomerulus, where the the blood vessels will be divided into plexus, that is called as the glomerulus, and outside we have a capsule, that is where the urine is formed, that is called as the Bowman's capsule. So renal corpuscle, this whole thing is the renal corpuscle, which has glomerulus, vascular part, as well as the collecting part. This is called as the Bowman's capsule. So this together is called as the nephron, and the remaining part of the nephron will be the renal tubule. So here you can see here, this is the renal tubule, which will be the other part of the nephron. So the nephron consists of two parts, renal corpuscle, this whole thing is the renal corpuscle, and the renal tubule. And the renal corpuscle, which is again made up of two parts, glomerulus as well as the Bowman's capsule. The second important part of the uriniferous tubules is the collecting tubules. These are the collecting tubules. For the details we will discuss when we discuss the histology of the kidney. So this is how it looks like. We will not go into details. So here are the collecting tubules, and here will be the glomerulus. These are the glomerulus which you can see here. Okay, so here is the glomerulus, and this is the Bowman's capsule, and here are the renal tubules. Okay, so this is how it looks like. So again, here you can see the glomerulus, as well as this is the Bowman's capsule, and here are the renal tubules, the ascending tubule, descending tubule, and other things. Okay. A very important part of this histological part of this is something called as the juxtaglomerulus apparatus. It is called as JG apparatus, or called as the juxtaglomerular apparatus. So what is this apparatus? So this juxtaglomerular apparatus is formed at the vascular pole of the glomerulus. We have seen the glomerulus at the vascular pole, where the there are two parts, the afferent as well as the efferent arterioles, which will be there. Afferent are those which are supplying the glomerulus. This is the glomerulus, and the afferent arterioles will be supplying the blood to the glomerulus, and the efferent will be draining the blood from here. So this apparatus consists of something called as the macula densa. So these are formed by altered cells of the distal convoluted tubule. So what is this distal convoluted tubule? If you see here, so here you can see. So this, as I said, as I said before, the nephron is made up of two parts, the renal corpuscle
as well as the renal tubule. Renal tubule has a proximal convoluted tubule. This is called as the proximal convoluted tubule, as well as this called as the distal convoluted tubule. And in between there is something called as the Henle's loop or loop of Henle, which has a descending limb as well as the ascending limb. So this distal convoluted tubule will come close to the glomerulus, and so here you can see here this is the glomerulus. So this is the glomerulus, and this distal convoluted tubule has come very close. And if you see, this glomerulus has the afferent arterioles which are supplying the blood to the glomerulus, and this is the efferent arteriole which is draining the blood. Okay, so this distal convoluted tubule comes very close to the afferent arteriole. So the macula densa is nothing but the altered cells of the distal convoluted tubule. So these cells of the wall of the distal convoluted tubule has altered themselves when it comes to the afferent arterioles. And then there will be second part. One is the macula densa, which are nothing but the altered form of the altered cells of the distal convoluted tubule. The second is the juxtaglomerular cells. Juxtaglomerular cells are nothing but the formed by the epithelioid cells in the media of the afferent arterioles. Okay, these are the tunica media of these vessels, which will have some cells which are modified themselves into epithelioid cells, and these epithelioid cells will come very close to the macula densa, which are nothing but the altered cells of the convoluted tubule, distal convoluted tubule. Apart from that, there are some agranular cells also between the macula densa as well as the glomerulus proper. So these three components are very important because they help in the production of a hormone called as the renin. They produce in the form of this JG apparatus helps in the formation of a hormone called as renin, which helps in the conversion of the angiotensin 1 to angiotensin 2. Okay, this angiotensin 1 conversion into angiotensin 2 is very important because it helps in the control of the blood pressure. This is how the blood pressure is controlled by this JG apparatus by production of a hormone called as the renin. Okay, so the details we will discuss when we discuss the histology in a separate lecture. So this is the glomerulus as well as this is the Bowman's capsule. These are the afferent arterioles which will be supplying the blood to the glomerulus, and these are the efferent arterioles. Now coming to the final component, that is the development of the kidney. So coming to the development of the kidney, kidney is developed from the intermediate mesoderm in the craniocaudal direction from 3 successive kidneys. As I said, the kidney is it starts developing in the pelvis, then it starts ascending, and during its ascent it also keeps on changing. So initially the kidney begins forming in the pelvis in the form of pronephros, then the mesonephros and the metanephros. These are the three components from which the successive kidneys are formed. Okay, the pre and the pronephros as well as the mesonephros are the temporary kidneys. So if you can see here, this is the mesonephros. Before it will be in the pelvis called as the pronephros, then it changes into mesonephros, and finally the full mature kidney is developed from the metanephros. Pronephros and mesonephros are the temporary kidneys, and the metanephros persists as the permanent kidney. So if you can see here, this is the mesonephros which has already been formed. Before it will be the pronephros, then it changes into mesonephros, and finally the actually the permanent kidney is developed from this is the metanephros. So kidney develops in pelvis as I said before, and later ascends upwards. So if you can see here, the kidney is developed here and it is ascending upwards through this mesonephros. Okay, so then you can see here it is in a higher position. Now it has come into the lower part of the abdomen. Now it is ascending upwards into the upper part of the abdomen. Now if you can see here, these are the suprarenal glands or the adrenal gland which are already there in the abdomen, in the upper part of the abdomen. They are not ascending upwards, they are actually here, and the kidneys go and its upper pole will be inserted into the suprarenal gland. Okay, so as you should remember that the kidneys are developed from the in the pelvis, in the form of pronephros and mesonephros. Then it ascends upwards into the abdomen, and the final kidney is formed from the metanephros. When it is ascending upwards, it is a very important change that even the arterial supply of the kidneys, initially, if you can see here, when it is in the pelvis, it is supplied by the iliac arteries. These are the iliac arteries which are supplying the kidney. Then as it starts ascending, the arteries also keep on changing themselves. Okay, so the blood supply, when it ascends upward into the lower part of the abdomen, will be by the lower part of the abdominal aorta. Now as it ascends upwards, if you can see here, it is disappearing these branches. Now the new arterial branches are formed. Then as it ascends upward into the actual position, then the actual true renal arteries are formed. This is important because there might be sometimes there might be arteries which are supplying the kidney, which might be coming from the lower part of the abdomen, or sometimes from the iliac branches also. So if you see in these pictures, some of the abnormalities of the kidneys are related with the abnormality of the blood supply of these arteries also. If you can see here, so these are branches which are coming from much more below. Okay, here if you can see here, this polar renal artery, which is an addition to the renal artery itself. So these arteries might be there sometimes. So it's the surgeon, especially the surgeon who is doing some surgeries on the kidney, he should always have in mind that apart from the renal artery, there might be some additional arteries which might be supplying the kidney, as well as sometimes the renal artery themselves might be arising from much more below than what is expected. Okay, so this is because of the difference in the development. Okay, so you should remember that the kidneys, the blood supply of the kidney keeps on changing. Okay, from different levels, sometimes from the common iliac, from the lower part of the abdominal aorta, or from the actual side, that is the upper part of the abdominal aorta. Then the fetal kidney, as I said, it will be in the form of lobes. Initially it will be in the form of lobes, which sometimes they never fuse. Okay, so that again leads to different types of abnormalities. We'll talk about that. Okay, so initially you should remember that the kidney is in the lobulated fashion, and then all these lobes, usually there are 10 to 12 lobes which have been fused together to form the proper kidney. Okay, which later might form the segments of the kidney. Okay, so that's why there are vascular segments within the kidney. Now after a brief introduction of the development of the kidney, now we can understand the different types of anomalies which might have arisen because of this development. Okay, sometimes there might be a very typical and very common abnormality or anomaly seen with the kidney is called as the horseshoe shaped kidney. So if you can see here, this is the picture showing the horseshoe shaped kidney, where the lower poles of both the kidneys have fused together. As we said, the lower poles are much more away from the midline compared to the upper poles, but initially during development the lower poles are much more closer. Okay, sometimes they might fuse together, and that leads to a condition called as horseshoe shaped kidney, because they look like a horseshoe. So that's why they are called as the horseshoe kidney. Sometimes the kidney has not ascended upwards. As we said, it will be in the pelvis initially, then it ascends upward. Sometimes there might be incomplete ascent of the kidney, so the kidney might be in the pelvis or sometimes in the lower part of the abdomen. If you can see here, this kidney has ascended up to its normal position, but the other kidney is still in the pelvis. Okay, it has not ascended. And you can see here, this is the suprarenal gland or the adrenal gland, which is in its actual position. If it has to ascend upwards along with the kidney, then it should be here, but because it is developed directly in the abdomen, in the upper part of the abdomen, so it is in actual position, but this kidney has not ascended upwards. So this is called as the pelvic kidney. Okay, sometimes instead of only the lower pole getting attached to each other, sometimes even the upper poles also get fused with each other. So it leads to a complete circular type of kidney that is called as the pancake kidney. It looks like a pancake, so that's what is called as pancake kidney, where the both the ends, the lower poles as well as the upper poles, will be connected with each other, and they will surround the whole of this blood vessel, especially the abdominal aorta as well as the inferior vena cava. So if there is a condition like this, there might be some compression arising because of this type of kidney on the blood vessel itself. Okay, so this is called as the pancake kidney, when both the poles, upper pole and lower poles, are fused together. Then I said the kidney have initially it will be in the lobulated form, which will fuse together. Sometimes there might be incomplete fusion of the lobes of the kidney. Then it is called a lobulated kidney. In this condition, if you can see here, there is lobulation still. So the kidney has not completely fused together, so it has lobules. Sometimes the lobes can be separated also. Okay, so those might be some of the conditions. Sometimes there might be agenesis of the kidney, or the absence of kidney on one side. Okay, sometimes this kidney might have gone to the other side, and both the kidneys might be on the same side, or they might be sometimes fused together like here. Okay, so both the kidneys may be on the same side, or one side of the kidney might be absent on one side, and there might be one kidney on the other side. Sometimes both the kidneys come to the same side and get fused together. Okay, that is called as the absence of kidney on the one side. Sometimes there might be double kidney, as I said, if both the kidneys come to the same side, uh, and sometimes there can be double ureters also. So as I said, there might be two kidneys on the same side, as well as there might be two ureters because of the two kidneys on the same side. And then I said the arteries which are arising keep on changing during its ascent. So sometimes the new arteries form, renal arteries may not be formed here, but the previous arteries which are coming from the iliac arteries, especially from the common iliac artery, might be still persisting. So then that condition, you should remember that this is because of the ascent of the kidney, but there is no development of the new renal artery, but it is coming from the old artery during its development. Okay, so that's why there might be renal artery arising from the iliac artery, or in the lower part of the aorta also. Okay, so these anomalies are because of the developmental difference. Even if there is slight change in the difference in the development, then there might be all these complications. And whenever you see about the anomalies, then you should know this is because of the difference in the development. So you should know the development of the kidney. And sometimes there might be double arteries. It might be a renal artery proper, as well as an additional artery, which is the polar renal artery, which might be arising from much more lower position. So all these are the anomalies of the kidney, developmental anomalies of the kidney. So if you have any doubts regarding this, you can always write to me and I will try to answer. And I thank all the authors of the books as well as the website from where I have taken these pictures for my presentation. Especially I have taken most of the pictures from the Gray's Anatomy, sometimes even from other websites from many different sources. So I thank all of them for their help, as well as for their pictures. These are my references. Thank you very much.